My name is Tomoko Kato from Japan. I'm a heart failure cardiologist, and I have been involved in Lvad and transplant recipients' care. In this presentation, I summarize the role of echocardiography in the management of patients undergoing ventricular assist device implantation and transplantation. As you all know, heart transplantation is a curative treatment for patients with advanced heart failure. However, transplant opportunity is severely limited due to donor shortage. Therefore, ventricular assist device has evolved into a standard therapy for patients with advanced heart failure, not only as a bridge to transplantation, but also as a destination therapy or a bridge to myocardial recovery. Echocardiography is a primary imaging modality in the assessment of cardiac structure and function in patients with advanced heart failure. It can be performed at patient bedside and results are immediately available. First, I will talk about the Rigor and Lvad echo. Preoperative assessment of Lvad candidate is very important. We should assess the Lvad eligibility and rule out any contraindications against Lvad surgery prior to an operation. Several surgical issues that can be surgery corrected at the time of Lvad implantation should be carefully evaluated prior to the surgery. The presence of clots, especially at the apex, should be carefully assessed because it will increase the risk of infracannular obstruction and or perioperative stroke. Intracardiac shunts must be closed at the time of surgery. Further, coexisting valvular heart disease should be assessed prior to the Lvad procedure. Concomitant valvular surgery can be performed at the time of Lvad implantation. However, although such an additional approach, including TVR, TAP, and aortic valve suture and such procedure, can provide possible benefits, data regarding its long-term effects are limited, and the indications are still controversial. Another important issue to be carefully evaluated preoperatively includes right ventricular function, because right ventricular failure after Lvad placement is associated with increased morbidity and mortality. During the operation, the TEE monitoring is very effective too. Other than the speed adjustment to avoid RV failure due to the excessive RV preload by Lvad support, several important points should be evaluated by intraoperative TEE. First, the air in the heart chamber should be confirmed. Careful observation of trapped air at the site of anastomosis sites and around the Lvad inflow-outflow cannula is required. Secondly, adjusting Lvad speed to maintain appropriate Lvad unloading without a separate shift under TEE guidance is required. The positioning of the inflow cannula at the apex should be monitored by TEE as well. Thirdly, as mentioned, the existence of valvular disease and intracardiac shunts can be corrected simultaneously at the time of Lvad implantation. Thus, such information should be communicated to the surgeon. Lastly, pericardial effusion and its amount should be also carefully observed by TEE. Cardiac tamponade can occur relatively common because patients under Lvad support require sufficient anticoagulation postoperatively. The purpose of post-operative echo in Lvad recipients are as follows: to carefully monitor device malfunction, to adjust appropriate Lvad setting, speed, it means appropriate peripheral perfusion and RV preload, and to evaluate myocardial recovery and to seek optimal timing for Lvad weaning. Conventional echocardiography allows us to monitor left and right ventricular dimensions, aortic valve opening, degree of mitral regurgitation, and cardiac output through RV outflow under LV support. Features are the essential information for optimized LV settings. We can also evaluate cannula flow, position and suctioning, as well as check any thrombus by using contrast as needed. Further, we recently published the usefulness of TDI and strain parameters to predict right ventricular failure after LVAD implantation in patients who were not planned to undergo biventricular support. RAMP study is very much useful for detecting LVAD malfunction, and we present a representative case in whom RAMP study enabled us to detect LVAD thrombus. Next, the role of echo in transplant recipients. Donor heart evaluation at the time of organ procurement by echo can provide a lot of information to the transplant team. The team can make a final decision whether or not to harvest the heart. We can provide tailor-made transplant medical management to each patient. Post-operatively, echocardiography helps early detection of rejection. Conventional echo parameters can detect diastolic and systolic dysfunction associated with acute rejection. However, these conventional parameters are not sufficiently reliable to guide the treatment strategy in asymptomatic clinically stable recipients. TDI and 2D speckle tracking echocardiography derived from LV torsion and strain parameters are expected to detect subclinical rejection. In summary, in this talk, I want to tell you all, echocardiography is a primary imaging modality to evaluate cardiac function in patients receiving LVAD surgery and heart transplantation. When performing echo on LVAD candidate and LVAD recipient, knowledge of LVAD physiology and potential complications is very important. In heart transplant recipient, early diagnosis of rejection and consequent timely treatment is essential. Therefore, echocardiography before and after transplantation provide considerable information in the management of heart transplant recipient. Newly developed echocardiographic modalities will emerge as useful follow-up tools for monitoring rejection.